Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. On this episode, we speak with Dr. Roman Gusztak, a pediatric anesthesiologist practicing at the Pattison Children's Hospital in Saskatoon, along with Dr. Anulika Nwakaeze, a PGY2 anesthesiology resident at the University of Saskatchewan, to discuss pediatric anesthesiology and what to expect for parents of children with an upcoming surgery. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come take a break with our host, Anesthesia PGY4 Alex Pellerin, and a multitude of brilliant and insightful guests as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Hello, everybody. Welcome back to another episode of Airway Breathing Conversation. My name is Sebastian Turcott, one of the residents with the University of Saskatchewan Anesthesia residency program here. And I have my co-host, Alex Pellerin, joining us again. Thanks for joining us, Alex. We have a super exciting episode today on pediatric anesthesiology. And so we've invited Dr. Roman Gusztak, one of our staff pediatric anesthetists, to come and chat with us a little bit about that. And we also have Dr. Anulika Nwakaeze, who's one of our second-year residents with our program as well, who's going to offer us some extra insight into some of her research around peds anesthesia as well. And then lastly, of course, special shout out to our IT guru, Dr. Alan Meldrum, also one of our anesthesia residents who puts in all the work behind the scenes for our episode. So thank you for joining us, guys.
Great to be here.
So happy to be here.
Awesome. So the way that we're going to structure this episode is we're sort of going to talk about pediatric anesthesia a little bit as a specialty, and then sort of dive into some frequently asked questions or expectations that parents might have when their child is going to have surgery here at the U of S. So, Dr. Gusztak, if you don't mind just starting us off with generally, like, what is a pediatric anesthesiologist, and what does that make? What sort of makes them different from a general anesthetist?
So a pediatric anesthesiologist goes through all of the regular training that a general anesthesiologist would do, and then usually one extra year of fellowship on top of that. So your med school, anesthesia residency, and then doing your extra peds training. I once heard you do a peds anesthesia fellowship to essentially take care of little babies, little neonates, kids kind of less than a month or so old, kids with syndromes that are just not very common, just try and get more exposure to that. And then kids with heart disease, primarily the cyanotic heart disease, or heart disease where your oxygen levels usually not higher than 90. And so that's, you're really taking care of really much more complex kids in peds anesthesia. That's why you do the extra training. As a general anesthesiologist, you can definitely take care of kids. There's a lot of really good general anesthesiologists who take care of kids. And that age cutoff is somewhere between 2 and 4, I think, at a lot of places. And usually it's for otherwise healthy kids without those syndromes, without those cardiac issues, or just things that make them more tricky.
Okay, so very cool. And so where did you do your training, by the way?
I did the whole gambit of training. Yeah, sure.
Very cool.
So I did medical school in Winnipeg, then did residency here in Saskatoon, and then was fortunate enough to actually go to Boston for my peds anesthesia fellowship, and then did a combined peds anesthesia and pediatric ICU fellowship there. So I was there for 3 years, and so learned a lot about pediatric stuff, and was really, really good exposure and training.
Okay. So. Awesome. Yeah, that sounds like an incredible experience. Great. And so then what does like a typical day in like pediatric anesthesiology look like?
Yeah, it's I would say there's maybe not a typical day per se. It's very it varies depending on your slate, right? So if you know what slate you're doing, then it's probably more typical. And say for example, tomorrow I'm doing just a full day of general anesthetics for kids getting MRIs. So things that you wouldn't expect really for adults, right? Adults, you say suck it up, go inside the machine, hold still, or maybe get a little bit of
Ativan,
something like that, right? And so you don't get that many, you still get some, but not as many general anesthetics for adults. For kids, particularly young kids, they just can't hold still. In the MRI machine, you need to hold really, really still. And so for pediatric anesthesia, we do a lot more out of OR or out of the operating room anesthetics, if it's for MRIs or CT scans or lumbar punctures for oncology kids and stuff like that, things that adults can just hold still for or kind of grit their teeth and kind of push through. Kids, we're actually, thankfully, we don't make them do that, right? We have the ability to give these anesthetics for that. So in terms of, getting back to the actual question of like, what's a normal day look like? It's, again, it depends on what you do. Sometimes you're in the operating room doing a day of ENT, ear, nose, and throats. You're doing a lot of tonsils and adenoids. Urology, you're doing probably a lot of circumcisions and things like that. And general surgery or pediatric general surgery, they do just a huge wide range of things. And so it's the constant factor is you're dealing with kids all the time. And but your days actually can be quite varied and usually predictable, but depending on what your slate is. But it's, there's a lot of variability. And the nice thing about peds too, peds anesthesia, just chatting more to the medical folks, is like you do everything, right? Like you're doing neuro, you're doing thoracics, we're doing like, you're doing the MITS. There's sometimes doing a double lumen tube in a teenager, or you're putting in a bronchial blocker in like a 3-month-old or something like that, right? And so there's this huge variety. And the only thing would be like the subspecialty peds anesthesia, where you'd need an extra fellowship if you wanted to do peds cardiac surgery or open heart surgery, which again is only done at a select locations here in Canada. And so anyway, so it is, I would say, if anything, it's maybe not super typical, but it's varied in your kind of exposure and just the breadth of anesthesia that you do. And the other thing too is we're taking care of kids who are 0 days old, usually not 0 days old, but usually like a couple days old, sometimes for some surgeries, all the way up to like 17, right? So you have this huge variety of cases where you're dealing with the really, really small and then like
they're really, really big.
Really, really big, like adult size, right? I remember Chrissy Urmson, this was before when we were at this was before when JPCH, our children's hospital, opened up. She was doing peds in the morning, and then she was doing adults. I think she did like, I forget what it was, a kid within the first week, and then she did like 100-year-old for a hip or something like that. So it was just like the variety and the breadth, right? Or just like, if you have a split practice, just the things that you can do, right?
Yeah.
So.
Very cool. Sounds like a super varied practice, which is, very rewarding probably. And then we were just talking off camera a little bit as well. Like there's also areas outside of the operating room where pediatric anesthesiologists work a little bit as well. And do you mind expanding on that a little bit maybe? Like some with the peds codes and traumas that you partake in as well?
Sure. Yeah. No, I think, so we do, at least at the University of Saskatchewan here, we have our kind of code team, trauma team. The anesthesia goes to those particularly in the emergency room for any of the traumas that come in, the level 1 traumas. And just essentially, the attending and the resident's always there before the attending, and but essentially to provide one, airway support, but also kind of hemodynamic support as well too. And just because, again, pediatric emerge doesn't see the same level of acuity as adult emerge does. And so we just have, because we see a bit more acuity, and I think we can help out with some of those vasoactive medications and airway instrumentation and stuff like that. And so anyways, and it's, to be honest, it's great to have support, right? Whenever you're in a crisis situation like that. So I think that's probably part of the model as well too. It's just to help people out and be like, hey, more hands on deck is better to provide better patient care, better patient outcomes than if you're limited by the amount of help that you had. And so, similarly, out of OR for codes, again, the codes in the hospital are run more so by PICU, but then if they need a hand with airway, then we're more than happy to help with that. And again, kind of other out of OR procedures would be kind of like what we talked about, MRI, CTs, and then we do a fair amount of oncology procedures as well too, lumbar punctures and sedations and stuff like that in a special little room as well. So.
Awesome. Yeah. And then just to pose the question to our two residents here as well. So both of you have done your pediatric anesthesiology rotations now, or part of them. What what differences do you see in a pediatric day versus just a general adult day?
I think the biggest thing is really learning how to build rapport with children, because when you're doing scheduled cases, they're coming in, and then you learn how to like interact with parents in addition to like interacting with the child, and depending on their like level and where they're at, which is totally different when you talk to an adult, because you just kind of tell them like, this is what we're doing an IV. And with kids, it's a lot more like finessing and like telling them, we're gonna have this great time, we're gonna like pick a smell for you to smell in your mask and do all that. So it's just like a new skill set to develop. And then I think for a lot of residents, initially it seems really overwhelming because of like pediatric like drug dosing and how it needs to be based on weight. And it seems like a lot to remember. But now I've done peds 3 times. And the last time I did it, I had so much fun because I'm like, okay, now I know what the drug doses are. Now I can actually like focus on the good skills and like learning from my bosses. And I thought I was someone who was like, I don't like peds. I don't want to do peds. And then the last time I did it, I was like, oh, it's actually so fun. Yeah. And all our pediatric anesthesiologists here, I think, are so approachable, such like kind people, and like good teachers. Yeah. Like we're really, really lucky here.
Amazing. Anything else to add, Anulika?
Yeah, I would echo Alex's sentiments. When it comes to pediatrics, you don't just have the one patient. The entire family unit becomes your patient in a sense. And you really do have to navigate and negotiate that relationship. You can't just ignore the parents because they're very much involved in the decision-making for their child or their loved one. So that's definitely a skill to develop, which I quite liked. I like interacting with patients anyway and building rapport. So it was nice to include the rest of the family as that unit of care. I really like that part. And then certainly the drug and airway equipment have to be sized and dosed according to the patients, their age, their weight. That's definitely a lot more nuanced, I would say, in pediatrics than it is in adults. In adults, there's always weight-based dosing, but you can like blur the lines a little bit. You can make educated guesses and be like, this is going to work. And usually it does. But for children, you have to be so much more precise with that, which can be a bit of a cognitive burden when you're first starting out. But again, kudos to our teachers and our coaches that we have here. Really, really helped, I think, to make that a lot easier for me. And so I really enjoyed my pediatric anesthesia rotation. It was a good time.
Nice. Very cool. Well, I think that might be like really good reassurance to parents, just knowing, the attention to detail that goes into the cases for their children, and the amount of thought that we put into this while we're looking after their children for their surgery is, there's a lot of thought that goes into that. Dr. Gusztak, do you mind just sort of commenting on why you chose pediatric anesthesia as a specialty?
Sure. Yeah. My approach is probably not the normal approach, but yeah, maybe a little unique. Initially, when I went into med school, I thought, I want to be a pediatrician. And so they always tell you to do electives and selectives or exposures. So I think I did one, and I was like, oh, yeah, I want to be a pediatrician. And so anyways, in med school in Winnipeg, I set up my pediatrics block in the middle of the 3rd year, and anesthesia just happened to be right before. And I was like, man, I really liked anesthesia. I didn't realize at the time that I liked doing things with my hands. And so I just thought, I'm going to work with kids. I'm the oldest of 6 kids. I was a lifeguard. I was a soccer coach. I was like, did all sorts of stuff with kids all the time, right? So of course I'm going to be a pediatrician. And then I do my pediatrics rotation, and I'm like, oh no, I'm kind of dying in the inside. And just because I didn't realize it at the time, but I wasn't doing stuff with my hands. And it was back in the day, it was fax this, fax that. I hardly ever got to see the parent or the patients and their parents. It was just like 5-10 minutes in the morning each day, right? And then multiply that by 6 or 7, however many patients you have. And I don't think I did a lumbar puncture. I think I saw a lumbar puncture. And so it was just like, it made me realize, like, man, you know what? I don't think being a pediatrician is for me. And so anyways, was able to get some other exposures. Actually, with family medicine, I was able to split up my GP or family medicine rotation with a GP anesthesiologist. And so got some more there. And then after that, I was like, I think I'm going to do anesthesia. And so anyways, that was the anesthesia. And then I was like, well, of course, if I'm going to do anesthesia, I'm going to do pediatric anesthesia because I like kids. And so that is the not common approach for kids, right? Because it's like, as you know, after you've done peds anesthesia, it's or I think all my other personality traits actually fit in very good. And that it's extremely attention detailed, right? You have to be very focused on your weight-based dosing, all your tubes and drugs and everything like that. And so all those little nuances there, which you've kind of alluded to there. And you have to be good technically, just to be able to get these like small little IVs and stuff like that, right? And so anyways, and you have to enjoy kids. And so anyways, I think it was my joy of kids that brought me in there. And thankfully, I'm good technically, and those other attributes was able to kind of grow and expand, or they just came easily. And so anyways, and to be honest too, like when I was in med school, I don't know how this happened, but when I was doing my electives, I ended up getting like a week of peds anesthesia as a medical student elective in Winnipeg. I got a week at Alberta Children's as a medical student.
Oh, wow.
And so I was like, because I was interested in peds. I was like, how do I do peds? I was like, yeah, I probably wouldn't recommend that much time to a medical student now doing an elective, doing that much peds, right? Just because it can be quite challenging. And, but anyways, yeah, so that was kind of I was kind of led by the golden path of their kids. Kids are great. I want to work with kids. But also too, when it can get scary pretty quick as well too, especially when you have really sick kids. And I think I was sheltered from that my first couple years. And then it wasn't until later on, it's like you're doing some of these really intense cases. It's like, okay, yeah, this can get pretty scary pretty quick. But I think what we do really well here is when we do have those intense cases, our threshold to call for help is so low. Call for help ahead of time. So we're having, usually it's these real small neonates or kids with these congenital cyanotic heart disease, where it's like, hey, you're calling in a second anesthesiologist or a second pediatric anesthesiologist, just so one person's managing one set of vitals, the other person's managing the other. And it really just, you can tell, just decreases the stress in the room. And then everyone's just able to, once they know their roles, are really able to care for the patient really well. And so I think I experienced that as a resident, which made me feel like, oh, I could do this, and kind of gave me confidence, right? Knowing that I couldn't do, there's still some things I would have to grow into and learn. And, but so anyways, yeah, so that's kind of the long-winded answer to why peds anesthesia.
No, that's amazing. And you can really see like your enthusiasm through it all, which is really amazing. And I think we've already put in lots of amazing plugs for our program and department here, but just another is the amazing collegiality and support that we get amongst one another.
Incredible collegiality. I think a lot of people wouldn't know that.
Yeah.
How, because I know that's something that really struck me first doing peds, was seeing like you and Dr. Gamble and maybe Dr. McCaskill all working together on this really, really sick baby, trying to get lines, trying to do everything together. And the room was very calm, even though I could tell this child was very, very ill. And I'm sure that if you asked the parents, they wouldn't have known that like 3 fellowship trained pediatric anesthesiologists were all working together to like make things as safe as possible for their child. And I think that's like a thing that we should let people know about, that, you know, people work together here to try to like have good outcomes and do the best that they can possibly do for their patients. So
yeah. And I think we do that for some of those, especially the little neonates. I think we'll routinely bring in the other guy, hey, Dr. So-and-so is here with me just to take extra special care of your kiddo, just because partly too, it's like some of those pre-op discussions, it can be really challenging to, with the informed consent, you want to give them all the information. Some of that information can be pretty scary and pretty terrifying, right? Particularly if it's a quick diagnosis or something really sudden or a new change coming. And then you're having to have these like really intense conversations. And so I think, so it is when those real very challenging cases come in. Usually if we're able to, we'll grab that second anesthesiologist, and a lot of times we'll just bring him into that induction room ahead of time and say, hey, this is Dr. McCaskill. He is here with me, and just to give a hand and stuff. So, And partly too, or just kind of say, because I think we actually learned that from the surgeons. The surgeons always grab.
Yeah,
not
they always ask for help.
Commonly they'll have a second surgeon with a challenging case, right? You don't really see that as often in anesthesia, particularly adult anesthesia. And partly too, it's like with a resident or even anesthesia assistant, right? It's like there's good support there too. But I think, it's all about kind of decreasing that mental stress, right? And as well too. And so, anyways, it's a fine balance because you also want to be having independent anesthesiologists as well too, and you don't want to be, having 2 anesthesiologists for every case, which just wouldn't be feasible, right? So,
Not in our current climate, I suppose.
No,
For sure. I think that was a pretty amazing overview. So, so the second part of our talk that we wanted to sort of discuss was, what parent expectations around what can they expect when their child is booked for surgery? What does the day look like? What are some frequently asked questions that you may get from patients or parents when their child comes for surgery? So just as like a general overview, what should parents sort of expect a day to look like when their child comes for surgery?
Yeah, no, good question. It's going to be a lot of fasting or not a lot of eating.
Yeah.
One thing that we are encouraging, and I think Anulika is going to go into this a little bit more, is just the fasting guidelines. And it used to be, so they still can't have anything to eat 8 hours before. And you'll go over all those numbers.
Yeah, feel free.
Yeah. Okay, no, or you can go. Okay, well, Anulika, she can go over the numbers. I think one thing that we're really changing in our discussions about fasting is to really encourage drinking of clear fluids all the way up to an hour before. And so I think that is kind of the mainstays. Before it used to be like, and maybe some of the surgeons' offices are still like this, where they're don't eat anything, don't drink anything, because just in case another kid cancels or isn't here, we'll be able to fit you in. But in general, it's like, man, there's just a lot of kids who just don't eat or don't drink, and they're just miserable. So anyways, I won't talk, you can chat more about that. But so I think all of that fasting duration will depend on how old your child is. Younger the kids in general get done earlier in the day. And so if you have a teenager, usually they're waiting to the very end or closer to the end in the afternoon. So they'll have to be fasting a little bit longer, just so that the kids who are 6 months or a year or 2 years won't have to fast as long, right? And so anyways, you don't usually, each surgeon's office is a little bit different, but I think usually you're supposed to come like an hour and a half, 2 hours before to the actual JPCH, to the registration area there. And then after that, you'll come into this PACU, or the post-anesthesia care unit. The nice thing about JPCH is you're in one room the entire time before your surgery. You have your surgery, and then you go back to the same room. And the rooms are all secluded. They have a glass door. And you can keep it. You're going to be the only person in there, which is really nice just for continuity. And so sometimes when the days are super busy, like with some of the ear, nose, and throat or ENT days, sometimes it can take a while to actually get into that room because there's such high turnover. So sometimes you're waiting in the registration area for a little bit. But that's usually just with those ENT days. And with the other days, usually get in there pretty quick.
Fair enough.
So.
Awesome. And I think the one thing that struck me the most about our new hospital, our new children's hospital, is how family orientated, that it really is.
The spaces.
And the spaces are all individual, and it really promotes, inclusivity for families. So we did touch on fasting guidelines a little bit, and Anulika, that's sort of what your research area is as part of your residency project. Do you mind telling us a little bit more about that?
Yeah, for sure. Thank you so much for the opportunity. My resident research project has to do with clearing up miscommunications around fasting guidelines for pediatric day surgeries. It was something I first noticed in the adult world, that there just seems to be a lot of confusion regarding how long am I supposed to fast for? What can I eat? What can't I eat? Which medications am I supposed to stop or keep taking? And in particular, in the pediatric world, the parents are usually the ones that are making those decisions on behalf of our patient, which is their child. And so if they don't understand what they're supposed to be doing, then there's no way that the child is going to be appropriately following our guidelines. And so I thought it'd be something interesting to explore as part of my resident research project. And diving into the literature, there does seem to be a lot of misconceptions regarding how long these little kiddos are supposed to be fasting for and what exactly they're supposed to be fasting from. And unfortunately, this lack of understanding does then feed into poor, lower rates of adherence with these fasting guidelines, which then is associated with increased perioperative morbidity and mortality even. So I think that as anesthesiologists, we can do a lot better when it comes to communicating these guidelines to our family unit, which would be the parents in this case. And so just to give everyone a bit of a refresher, and feel free to jump in if I make a mistake here. So when it comes to, say a kid is taking infant formula and they are scheduled for a surgery, they have to then stop taking that formula 6 hours prior to their scheduled OR. If they're taking breast milk, then it becomes 4 hours. And like Dr. Gusztak was saying, classically, if they're drinking clear liquids, so water, apple juice, anything you can see through, classically, they would have to wait 2 hours. Okay. But recent literature has suggested that we can liberalize this to 1 hour. And this is associated with lower rates of basically derangements in the body. So their glucose is more under control. There's less swings in their blood pressure. They themselves are a lot happier. And in turn, their parents are happier and they're less likely to give in to the demands to feed their kids. That being said, sometimes parents do give in. And unfortunately, a lot of parents will actually misrepresent the child's fasting status, which is also associated with bad outcomes. Yep. And so I think we can do a lot to communicate this to parents. And going through my pediatric anesthesia rotation, I took the opportunity to chat with some parents about what their understanding was. And I found that in cases where the guidelines were not followed, it didn't have so much to do with, I just didn't read the instructions, versus I didn't understand the rationale for it. And truly the rationale is that we don't want kids to aspirate when we induce them, meaning we don't want things to come up from their stomach, up their esophagus, and then into their lungs, which would be very, very bad news. And so when chatting with parents, when I took the time to explain that more, you could really see a light bulb going off in their heads, and they understood it more. And when I said, if you had been provided with this rationale and this piece of paper that you had with instructions, would that have changed whether or not you would have fed your child? And the parents would be like, well, of course, I don't want this bad outcome to happen to my kid. And so that's something that I've been exploring further as my resident research project. I think especially with the fasting guidelines being liberalized and that kids can drink up until 1 hour prior to their surgery, it really does make a big difference for parents. And I think that's something that we should promote. Certainly, it is going to be an evolving change in that we're going to have to coordinate with our surgical colleagues because they do typically just say nothing to eat after midnight, which is so tough, especially for young kids. I mean, for adults, it's tough. Imagine being a 6-month-old who's dependent on feeding every 2 hours or so, and then they get nothing for 8+ hours. So I think there has to be a lot more communication between our surgical colleagues, our nursing team as well, and us anesthesiologists being perioperative physicians to promote this change.
Yeah, absolutely. I think that's, I think you said it pretty perfectly there. There's a reason behind our fasting guidelines, and I think just communicating that a little bit better would go a long way. And in our department here, we're doing another research project on using ultrasound to assess gastric contents before surgery and things like that. So just for our listeners to look out for that, research once it's eventually published. I think it'll be really enlightening and new tools to see, can we use ultrasound to better predict the risk of aspiration in the pediatric setting?
I'll maybe just say one thing. I think they do this at Alberta Children's in Calgary. And as our other pediatric anesthesiologist, Chrissy Urmson, said, we should adopt this. And it's think to drink. And so to be intentional in terms of actually not pushing fluids, but being very liberal. And so it's something that we've tried to do a little bit more, and we're getting better buy-in from PACU. And I think it's a little bit of a tricky balance because I think the PACU nurses don't want to offer them a drink and then potentially delay surgery time, right? Because just for the listeners, the operating room is one of the most expensive areas to run in the hospital. You have multiple physicians, multiple nurses, and so you don't want to just have that room sitting idly, not doing anything, right? And so I think that's maybe where some of the very conservative approaches to fasting guidelines have come from. But if we were trying to encourage the PACU nurses, hey, if all the kids before this kiddo are here and there's still 2 hours of operating room time, definitely offer this kid like some water or apple juice or something like that. We had, there was one very unique mom of an oncology kid who gave their kid a slushie. And we're all kind of like, oh yeah, slushie, ice. Yeah, I guess that's clear fluid. So then you know what, our charge nurse, she actually put in a bid to actually try and get a slushie machine for PACU. And I don't think we got the funding for it. But anyways, it was just like, how amazing would it be to have a slushie?
Love that.
Yeah, that would be great.
I would love that.
I think the staff would love it.
I know.
Much.
So it's trying to like, encourage them to do that. Or if it's even too, like giving them a popsicle ahead of time or something like that, right?
Yeah.
And so anyways, I think, as you're alluding to, Anulika, there's a ton of re-education.
Yes.
There's a ton of giving nurses autonomy with sometimes they're probably going to potentially mess it up, or it's like, and if you have to wait half an hour, you have to wait half an hour. I think it's, in the grand scheme of things, it's kind of, I think it's better to overdo it, not overdo it, that's the wrong word. It's better to give a lot of fluids to a lot of kids on the off chance that 1 or 2 rooms might be delayed in a year versus not giving all these fluids to so many kids, but having a highly efficient operating room, which is still going to have delays because it's an
that's
operating
just the
room.
nature of the game.
Yeah.
It's just the nature of it. Yeah.
Awesome. I think I'll just throw this out to the 3 of you, but are there any sort of frequently asked questions in your experience in pediatric anesthesia that parents will ask you that you think our listeners would, benefit from knowing?
I think that we stay with your child the whole time. I think sometimes there's like a misconception about what our job is, or like people don't even really know what anesthesiologists are. And we've like talked about that on another episode too, but we're there the whole time monitoring your child very closely. Like our number 1 job is always safety, and like number 2 job is always comfort.
Yep.
So I think those are the goals that we try to achieve every single time. And then we're there every step of that like perioperative journey with their child. So
for me, and I might hand this off to Dr. Gusztak to expand upon further, as my experience with pediatric anesthesia is very nascent. But a question that I got quite often was, can I come in the room with my child? And truly, that's something that's examined on a case-by-case basis, at least at our institution. I'm aware that other institutions have hard set rules, as in no, parents can never come, or yes, parents can always come. But I think for us, it's definitely a lot more individualized based on the patient themselves, what the precedent has been, the nature of the surgery and the anesthetic itself. But I think Dr. Gusztak would have a lot more insight to share if you're willing.
Yeah, no, I can share. Yeah, definitely. Yeah, no, that definitely is a question that we get asked pretty frequently. There is no institutional policy to be like parents can or parents can't. It is, as Anulika was saying, very like patient specific. And a huge part of it comes down to is the kiddo nervous? How nervous are they? And also too, the parent coming in will usually bring a benefit, can decrease that anxiety for the child. Sometimes we'll use a pre-medication if the parents are open to that, and giving them a little bit of something just to kind of take the edge off. If that's the case, usually you don't need the parent inside there because the child's just not
chilled out
and just not fully aware of their surroundings, or they are, but it's, less anxiety. And the big risk that we think about in terms of peds anesthesia when bringing in the parent is just in case if the parent were to have a fainting spell or if they just don't handle their kid going off to sleep very well. It does look really strange with your child going off to sleep, particularly with the inhalational induction with the little mask and everything. I'll do a little bunny trail. Your 2 main ways of going off to sleep is one with a mask, which more commonly we'll do with kids. Very rarely we'll do that with adults. And the other option is an IV. Most kids hate IVs, and it can be, I think, a little more traumatizing to do an IV. That being said, you can do a lot of awake IVs, or I should say awake but distracted IVs with the freezing creaming and everything, and they can actually go very, very well as well too. But for kids who are really nervous about needles, or if they've been poked lots, usually that mask technique is the common way, or a common way that we'll do that. And when they do that, it's very common that their eyes kind of roll in the back of their head. There's this disconnect between the brain and the body. Their arms and legs move and jiggle and everything. And it just looks very strange. And it can be very upsetting. And so the thing is, it's very predictable just because it's the kind of the pharmacology of the medication that we give. And so so if a parent would get uncomfortable with that, and if they were to start getting woozy, fainty, or something like that, it means we have to now take our attention away from their child who just got off to sleep. And there's some, just things we have to be very careful and very vigilant for just as a kid gets off to sleep. And we don't want to have to be dealing with two patients at the same time. And so, and those so it's kind of, it is a judgment call to be like, okay, how can we, again, bring comfort to the patient the best, but also their number one thing that we're always focusing on is their safety. So.
Yeah, that's what I was going to say too. Like, it's really just about the safety of the patient. And like, you just have to be doing what's best for the patient. And I think even though maybe parents want to be there and maybe that's like not the safest option, they just have to sometimes be, told, we just want the best for your kiddo during their surgical stay here. Which can be hard to hear sometimes, I think, for parents. It's scary. It's scary coming. It's like, it's a scary, traumatic thing, like leaving your child in someone else's hands. But like, as you mentioned, Dr. Gusztak, you went to school for a very long time to be a pediatric anesthesiologist. So,
and I think too, like, and I'll just say the flip side of that, some of these kids who've come in for multiple procedures, their parents have come in a ton of time and they do amazing. Like they know
really great.
They know exactly what to expect, right? And so it's like, okay, they know their eyes are going to roll back. They know their arms and legs are going to wiggle and just kind of do some unsightly things. And it's like, okay, nope, yep, seen it, done it. And so they can bring a lot of, there's just an understanding of what's going to go on. And so it's kind of, so.
Awesome. And again, that just shows how every patient's a little bit different and we treat everybody just a little bit differently based on, how they present. And so we focus all of our attention on them, for every case, which is amazing. Does anybody have any insight on how parents can prepare their child prior to surgery? Or like what can parents do, the night before surgery or the day before sort of as part of their child's care team?
Can jump into that if you like.
Sure.
So we do have a dedicated child life specialist. Her name's Carly. And so she can actually meet up with you and your family, or they can actually give books, little booklets that kids can actually color and draw and then just kind of see all the different pages of we're going to go here and then here and then here and all this stuff. Some kids, if they might not like the face mask as much, I think she can, I'm assuming she would be able to give you a face mask if you came in for an early visit to do that as well too. Again, we have a ton of kids who come through the operating room here. So usually child life is kind of reserved more for like kids who are maybe a little more nervous or anxious than the average bear, or some other special needs like autism and stuff like that. But I think you'd still be able to get that color book and everything too. And then there's the medical term is like cognitive priming, right? Or it's like you're just kind of telling them, hey, this is what you're going to be doing the next day. And it just kind of orientates them to be like, this is what we're going to do, and can help minimize some of that stress and anxiety and everything. I know there was a family that their kiddos were coming in for a medical procedure once every 3 to 4 months or something like that. So very predictable. And they came in for a pre-op consult. And I gave them each a face mask. And I said, hey, this is your face mask. Put whatever you want on there. So they brought in the next day and it was just colored or covered with stickers coloring everything else. And then they each had their own particular smells, if it was bubblegum or strawberry. And so you'd put that in there and they'd be like, oh, it doesn't smell like bubblegum anymore. So we'd stick some more bubblegum a couple months later. And so anyway, so that when you have kids coming in for repeated procedures, then you can, I think, make some of these even extra special bonds. But it's something that they've been trying to do more and more, is just even giving those face masks to the kids with the scents while they're in the pre-op area ahead of time, just so they get used to that and used to smelling it and stuff like that. So
awesome.
But,
and I think, again, we were talking off camera before our podcast episode, but I think you were mentioning that sometimes parents or patients can do a walkthrough of the operating room before they come for surgery. Did I hear that right?
Again, with child life, I don't think they can't go into the actual operating room, but they can go to the PACU and stuff like that and just see those rooms. And just kind of gives you a lay of the land that here's registration, here are these other areas and whatnot. And particularly, I think it's beneficial for some kids who are very visual and if they're maybe a little more nervous and can just kind of be like, hey, this is what you can expect. And then, what will be done. So
amazing. I think that'd be super beneficial for a lot of children before they have surgery.
I'll maybe include one topic that frequently comes up that there's a little bit of confusion is about kids and colds. And so
thank you for bringing that up.
Get a ton of colds, particularly if they're in daycare, preschool, school, you name it, they get colds, right? And so with COVID, it was very strict. You have any sort of cough, cold, any little sniffle, like bam, you're canceled, right? Just because our testing and everything like that was it was a challenging situation. I think challenging for parents, challenging for us. And so anyways, pre-COVID, we had guidelines in terms of when is a kid or a child too sick for an anesthetic. And so the skinny or the very kind of Coles Notes version is, or even before I say that, I'll say something else. Your kid can look really good or can look sick, but a happy sick, and we still postpone their surgery. And you're like, man, why are you doing that? Like, what's going on, right? And so the thing is, if a child has a cold, and if they have certain symptoms, which I'll kind of go into in a little bit, they're just really high risk of having almost like a little mini asthma attack under anesthesia. And so we're trying to make this judgment call to be like, how bad is their cold? What's the likelihood of them having a bad respiratory event inside the operating room? We do a really good job of treating those things, and most of the time we can get out of it. But you can almost have like little mini asthma attacks. You can have what's mucus plugging or all these secretions in the tube, which is more significant in a little kid because their trachea is just smaller, right? Or their windpipe is a lot smaller. The tube's a lot smaller. It can get blocked off with secretions, and it's like that. It's no fun doing that, right? And so less of an issue than adult anesthesia because the tubes are so big and usually the secretions aren't that big of an issue, right? But and so sometimes kids would have to stay overnight needing oxygen and things like that if we proceeded with an anesthetic where they're maybe a little too sick. Very rarely would they need to go to ICU with a breathing tube in place. And so we've had, again, not very common, but it's happened. Thankfully, not that often because, again, we're doing these judgment calls in terms of all that stuff. And I should preface, that's for elective surgeries, right? Stuff that doesn't have to get done. If someone has acute appendicitis or acute fracture, something like that, we do them regardless, right? And we just kind of know, okay, these are some of the other risks that are going to go on with that. And so if your kiddo, what we're really trying to differentiate is, do they have some sort of upper respiratory tract infection versus a lower respiratory tract infection? So if you have a dry cough or a little bit of a clear runny nose, that's not as severe. Usually it's more of a mild illness as compared if you have a wet sounding cough or if you have pretty like colorful snot coming out of your nose and if you have a fever. If you're kind of feverish, lethargic, that's pretty easy. Like, no, we're not going to do that because the risks are just very high under anesthesia. And then to try and differentiate, okay, is this a wet cough versus a dry cough? We'll take a listen with our stethoscope. Usually if I hear anything in their lungs, I just kind of tell that to the parents to be like, you know what, the risk outweighs the benefit in my opinion. And we could wait another 4 weeks. Your kid will come back and then we do the procedure. The catch-22 is they're a little kid, they're in daycare, they're in elementary school, and they're always getting colds. And so where we're a little more lenient with this is kids getting ear tubes, they're usually always sick regardless, right? And the anesthetic you give for that is less invasive. It's just a mask. We're not doing a breathing tube or anything like that. So our threshold to let those kids go and get them done is, I say, much lower than if you're actually getting your tonsil or your adenoid taken out. If you have a bad infection there, that's like, you know what? It's safest to postpone and delay, as hard as that is to hear, because I know parents coordinate time off and everything else, and you're being told the last minute, be like, oh, my kid is getting canceled. And so one thing I'd recommend is if your kid or if your child does have a new fever, a wet cough, or just really lots of nasal secretions coming out, and if that's a day or two before your actual surgery, call the operating or call your surgeon, and then they can actually make a judgment call, or they'll call us, and usually by that time they know who the anesthesiologist is, and sometimes we can even give you a phone call and just figure that out a little bit. It's a little tricky because we can't actually listen to your child's lungs, which is important to do. The other thing I do, again, this would be more for the medical or the residents who are listening to this, there's nothing in the data stating this, but if a kid's SAT is less, or if their pre-op SAT is less than 97 or even 97, it kind of puts my spidey senses up to be like, there's something going on with this kid. Maybe they just had a very active finger, like a lot of kids do. And so it could just be not an accurate reading. But if it's 97 or less, and if they have a current cold going on, it's like, you know what? That's kind of the first strike in my own kind of little mini algorithm. And the other thing too, again, to the residents, when you're doing that auscultation ahead of time, you can get burned if a kid is just doing small little breaths, right? And so they aren't cooperative. They breathe at whatever tidal volume they want to, right? Or whatever breath size they want to. And so I've been burnt a couple times where it's like, oh, they sound fine. And then you go ahead, do your anesthetic. Of course, you're giving nice big tidal volumes with your anesthetic machine. And my goodness, you're just, like all these wheezes, crackles, and the high airway pressures. And you're like, oh, this kid snuck through. So anyways, and then you just go through your pathway. And so that's the thing. You have all those things set up. And for treating mucus plugging, bronchospasm, decreased compliance, right? And if anything, from a resident standpoint, I think the residents who just graduated, or even probably like yourself going into R4, kind of had a little bit of a disservice during their peds blocks because you probably never saw that many
because if they were sick, they were just canceled.
Yeah.
Totally.
And so you don't get to actually deal with the intraoperative management of bronchospasm, mucus plugging, and all that stuff. So anyways, which pre-COVID was like pretty common. And so you're always trying to, it's that balance between what is best for the patient, what's safest for the patient. You don't want them to have an inadvertent admission to hospital or like worst case to ICU or something like that, right? And so the other thing too, I'll say to parents is it can be really tricky if your kid is right at the start of a cold. You don't know if they've just got cold symptoms for 24 hours. Is this what I call like a pansy virus, like rhinovirus, right? Rhinovirus, the one that usually just causes like a little bit of a clear runny nose. Or is this like RSV, influenza, COVID? We test for COVID if they would have symptoms. But to be honest, like RSV and influenza, especially RSV in little kids, like, man, it is rough. And so that's the tricky part. If they're right at the beginning of a cold, it hasn't got to the height of it. So usually if it is RSV or influenza, commonly those kids will get a little more sick. And it's just easy clinically to be like, okay, you're 2 days into your cold, you're looking pretty sick, we're not going to do you. But if it's very early in the disease process, you can get fooled, do the case, and then get a lot of intraoperative and postoperative challenges from a respiratory standpoint. So
awesome. I think there's so many amazing takeaways from that. And just like, there's a lot of considerations that either practitioners or parents may not know of when their child has a cold or a runny nose and they're coming for surgery. But it's not just, it's the type of procedure or the type of surgery, whether it's elective or can we postpone this for later or not. But then I think you also outlined really excellently that even if patients do have a reaction to their anesthetic, we're very well trained to manage it and get them through it safely. So, yeah.
So anyways, I just wanted to clarify that. And just to give a little insight, if for any parents listening, if you're ever concerned about, man, this cold, call your surgeon's office, let them know, and then the surgeon will either make a decision or commonly they'll contact the anesthesiologist as well too. So
amazing. Anything else? Anybody else wanted to add?
In general, pediatric anesthesia is very, very safe. So I think none of my children have had surgery. I have 4 kids. And so I remember, again, being the oldest of 6 kids, growing up, doing all this stuff, and going down to Boston. I was married but didn't have any kids. And you definitely become a better pediatric anesthesiologist once you have kids. And it's, you just think of things differently. And so like, is this safe? Like, I'm actually handing over my baby to you, right? Like, particularly when they're like, when they haven't had anything else done, and particularly when they're young, like still less than 1, but didn't need a long hospitalization for anything else. It's like, it's really hard. And so anyways, it's in the grand scheme of things, like pediatric anesthesia has come a long ways, and we, do our best to take care of those little kiddos. And it is safe. There are rare things where some things go bad or wrong, but we try, I think in anesthesia, we do a really good job trying to think about those ahead of time and just tell parents, hey, these are the risks. But in general, kids are resilient, and they're fun to play with. I shouldn't play. It's not play, but fun to interact with.
Yeah,
I think
fun
of
to
it as
interact with.
play, I should say playing, because I have my kids at home. I was playing with my 4-year-old this afternoon. But they're just fun to interact with, and they're just so resilient that even if a bad thing were to happen, they usually bounce back very quickly, and much more quickly than adults do. So,
so cool.
One thing that Dr. Urmson told me once, which is one of our pediatric anesthesiologists here, that really resonated with me. She said it's really easy to take care of kids because it's so easy to have like so much empathy and care so much. Because kids just like they have good intentions. They're just trying to live their best life. And, the things that happen to them are never their own fault. Like when you're taking care of kids. And that just like really resonated with me, because I think about like when I go to some of the traumas or things that we have to deal with in the adult world. And it's like, ooh, this person was drinking and driving, which is never, like, obviously we're still going to provide them with the best care possible, but it's totally different when it's like a kid that was placed in this situation that had no control over like their surroundings, that then this thing happened to them. Like, you care so much and you just really want the best for them.
Amazing. Well, like, just to echo your sentiment there too, like my wife and I, we just welcomed our first child. And I think just going through that entire process has already started to sort of change the way that I practice. You just think of things a little bit differently. And I think it gives you a different perspective on the type of medicine that you're wanting to practice, in your career. So very cool. So I think we'll wrap things up there. This has been an amazing discussion. Thank you, Dr. Gusztak. Thank you, Dr. Nwakaeze, for joining us.
For coming.
You're welcome.
So excellent.
Yeah. And Alex, thanks again for co-hosting.
Anytime.
Good luck with your big exam, but we look forward to having you on again.
Yes, absolutely.
And thanks to our listeners for listening, and we will talk to you guys next time.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.